Welcome, Annette and Dan. It's great to see you here, and we'd like to hear your story of the Whitmore Centre, which is something we feel is very important to us in the UK. If you could just tell us how you came to set it up and how it runs at the moment.
Well, thank you very much, first of all, for having us, and we're excited to be here. We first set it up really by just a casual conversation about what it was that was lacking in services for patients with chronic fatigue or ME. And Dr. Peterson had a wonderful suggestion. Went back to my husband. We began to talk about how that might happen, and realistically realized we could not do this by ourselves. So we began a foundation, pulled together some science from that foundation, and then went forward to our state legislature and asked for funding. And that really was the beginning. I'll let you.
So you're getting funding from the state legislature?
Yes, in 2005 there was a bill that was written for $10 million for a combined project, and the combined project was the University of Nevada Medical School's new research entity. Nevada Cancer Institute needed some building space in northern Nevada, and our project, which is approximately 15,000 square feet.
Right. Very good. And what do you hope to put in there, Dan?
Well, the concept was that it's such a heterogeneous disease with such chronicity and such a great cost that it would be best handled by a center of excellence. And so my concept was to build a center where we would be able to do translational research as well as provide clinical care in a comprehensive fashion for these patients, because they're so disabled that it's hard for them to get all the components. And our dream, which has now become a reality, is to provide, diagnostic technology as well as clinical care, as well as all the ancillary things that are required to take care of these people, such as psychological services, rehabilitation services, legal services for helping with disability issues, etc., as well as education, hopefully, of physicians and medical students.
That sounds pretty comprehensive. How do you handle the question of the investigative medicine, where you're looking at various tests that you might think are appropriate? Are they going to be available on site with dedicated equipment, or are you going to go out to centres with the appropriate equipment and techniques?
What's somewhat unique about the way we've constructed this institute is that we will have in-house research in the same building as the clinical, and that it's a new idea that we're thinking out of the box, so to speak, with respect to doing that. And my reasoning for that was that we could have that direct day-to-day contact with the basic bench researchers in order to problem solve more quickly. It also allows us to recruit the best people, and we've had fair success in doing that already to the Institute. But certainly, if the university has resources that we can use from outside the Institute, we'll certainly do that, as well as collaboration nationally and internationally.
And also, I think, directly to answer that question, for instance, neuroimaging is very important in this field, and we have only so many dollars, so I think what we've really decided to do at this point is to use another group, and already has all of the state-of-the-art equipment, and they're very close to the Institute. They're about 1.5 miles away. We decided it'd be a little cheaper to buy a van and have our patients go over there, and it's been a wonderful time setting that up. We've had a great time setting that up.
So you're identifying the sort of useful resources outside of the Institute as well as sort of within.
Yes.
And accessing those on a sort of pay-as-you-go basis, really. Yes. Yeah.
Absolutely. But for the most part, we're trying to be as self-contained as possible.
Right.
And we've been really fortunate in being able to raise the funds for that kind of space. And the idea, Dr. Peterson talked a little bit about having that bench research right next door, literally. We'll walk out our doors into the laboratories. We've already hired a laboratory researcher, a couple of them actually, that'll be working on our projects.
Right. So who chooses the projects? Is that down to you, Dan?
I'm afraid
Excuse
that
me.
we had the sort of crisis of thought with respect to prioritizing.
Right.
And my background interest has been chronic immune derangement in this group of patients, and so that's what we've chosen to pursue with reactivated herpes viruses, etc.
Right.
But it was a matter of prioritizing. You can't be the best at everything.
No,
So,
right.
and I would point out that a very critical reason why we were able to do this in Nevada was because the Nevada law requires insurance companies to cover expenses related to chronic fatigue in Nevada.
Right.
So that's a very unique circumstance we have.
Right. I think immunology is a big area where there's a lot of interesting things happening. Do you use any tests, sort of part of the diagnosis, which might be easily transferred to another institution, say in the UK?
I think it's the basis upon which I make the diagnosis the majority of the time is on immune derangement, such as abnormalities of the antiviral pathway and abnormalities of natural killer cell function. And the more sophisticated we get, the more we find with respect to these abnormalities. And the technology is certainly transferable.
Yeah,
And
thank you.
I think the viral arrays also are the viral tests are becoming more significant
Right.
for the viral reactivations. And
Yeah, I think one concern is that we're hearing stories about the herpes 6 virus being a big player in this. And there is some indication that there's effective drugs for herpes viruses, which would be life-transforming for people who are affected by herpes virus. But there does seem to be quite a big body of evidence showing that enteroviruses, which are not in the herpes family, are also implicated in triggering this immune dysregulation. How do you propose to handle the sort of people that the infections that are outside the box, as it were, outside of the herpes box or the chlamydia box or the rickettsia box, where you've got treatments that could be effective from the present pharmaceutical armamentarium?
Well, I think subsetting these patients is absolutely critical. I mean, all of us who are involved in this on a day-to-day basis realize that, and people may have different reactivations or different perturbations of their disease process. And I personally have found that these gene array screens have been very, very useful in rather quickly sorting out those subsets. So if somebody really has their origin as a rickettsial disease or as West Nile virus or whatever it may be, especially those that are amenable to treatment, I totally agree with you. Hopefully there'll be protocols so those people can be sorted out more quickly, and that in fact is one of our goals.
Right.
So we don't have this persistent 5, 10, 15 years of illness, which in what may have been treatable in the first place.
How quickly would you like to get hold of a patient who was ill? I mean, how quickly is realistic? I know the definition says 6 months, but before you do anything, and that seems to me a very long time.
I think in reality, by the time I see them, as a tertiary referral source, they've been sick probably 5 or 10 years. But I'd much prefer it. I'm much more successful in treatment when it's much earlier than that.
And what do you think the chances are of what's stopping this early diagnosis and effective early treatment? Is this medical education or bias in the system or what?
Well, I personally think there's a large amount of ignorance on the part of primary physicians in recognizing the syndrome and in referring appropriately. And that's driven in part by the economics and time constraints and things that are present in primary care now.
I think one of our goals is the educational piece and educating physicians. But as the mother of a patient, and the more that I learn about this illness, the more involved I become. I'm one of those that believe it would probably be better handled by someone who is specifically educated in this. I think it's a very complicated illness, and it really isn't suited well for primary practice with the short time constraints that the doctors have and the limitations. So.
But a good primary physician should be able to say there's something going on here that I don't like. It could be serious. It could have long-term consequences.
Right.
Get seen by somebody who's a specialist in this area.
Yes.
And let's check that one out. And that could short-circuit the delays.
That's exactly correct. And if we had a reliable, well-accepted biomarker, it would be even easier.
Yes.
Because then you could direct at that level, these are the tests or tests you need to perform in order to perhaps put that person in that diagnostic category.
Do you have any biomarkers that you think are helpful to a primary physician?
I think there's some that we would say have international agreement are useful in the vast majority of the patients,
Right.
such as low natural killer cell function. Is,
Right.
you know, almost every society that has the technology to look at it has reported that.
Right.
Doesn't help you particularly with what the pathogenesis is, but at least it's a marker that's pretty reliable.
Right. And how expensive would that test be to do in your facilities? Would it be something you can run fairly easily, or?
It runs about $250, so
Right.
100 pounds these days,
Yes.
you know.
Yeah. Not quite as much,
Very
but a little bit more, but not a lot. Well, that's very encouraging. One of the biomarkers that appears to be emerging from some UK research is the one for high sensitivity C-reactive protein, which is a marker for oxidative stress, really, and inflammation. Have you used that at all? Or?
I have rather extensively, and the problem, of course, is that it's very non-specific.
Right, well, that's true, yes. Do you see that raised in many in your patients? Or?
At least 50%.
50%.
Yes.
So at least we've got somewhere with really quite simple tests and really quite cheap tests that could begin to put a marker on these patients saying this might be ME and needs to be looked at by people who are experienced and expert in the field.
Right.
And you will go to Nevada. Well, we'd like them to go to somewhere in the UK.
Exactly.
Nevada's a long way away,
Yeah.
and flying there is not easy for ME patients.
Well, I think the biggest probably strategical problem for patients is they get categorized very early as being psychiatrically ill.
Mm.
And that often delays their proper diagnosis and treatment for a long period of time.
We find that very much in the UK. The psychiatric diagnoses that are presented and the treatment that follows are basically ineffective. Great claims are made for their efficacy, but when you check it out, and especially when you check it out with the patients, they find it not to be of much help. So I think we've got to somehow clear this hurdle that's put there, or get rid of it altogether for patients to receive the kind of analysis and diagnosis and treatment that you're offering. How do you get around it? Is there any way around it? Can you give us any help on this one?
Well, we have some of the same problems. So I generally work on the premise that most of the immunological abnormalities and viral reactivations and hard findings are not found in primary psychiatric diagnosis.
Right. So we need to be looking at the immunology as a starting point. But there are other things that emerge, things like the cardiovascular effects and the dysautonomia, which is associated with many people with ME, and the tilt table testing that's very widely used. Is that something you'll be planning to use, or are you just sort of feeling your way into that one?
It's we certainly use tilt table, but it's obvious. It's a very expensive test in the United States, and,
Right.
and we can do the same thing in the office and demonstrate inappropriate tachycardia and
Right.
hypotension, and it isn't as big of an issue. Certainly it's a big part of the disease process, but the documentation isn't as big of an issue.
So we need to train our medics about these simple tests.
Absolutely.
Standing for 20 minutes or whatever, and measuring heart rate, sitting and standing,
Exactly.
and things like that, which are relatively easy to do, and a good physician should be able to do very effectively in 10 minutes.
And very cheaply.
And very cheaply, yes. So again, they've got clues that would help them to make a referral to a centre of excellence. I like the term excellence. We do have some people in the UK who are capable of manning such a centre, but we need to facilitate the collaboration of such a centre, and we're looking very much to do that. And we're hoping to gain very much from your advice and experience.
Well, we hope to be able to share that with you, and certainly as we're learning as we go along, there isn't a roadmap here, but we've found that the more we collaborate, the much easier the road is. So we've got some collaboration with the federal government, from the state, private sources, and bringing a lot of researchers into it who have come from other fields has also been very helpful. So.
Right. Well, that sounds very exciting, and we certainly want to do something of this kind, and just to find out the ways of not falling over and tripping over our feet would be very helpful. You mentioned the legal side as well as being part of the provision that you make in the centre. This is a big issue for many of our patients who are very often very poor. They're made poor because they're looking at all kinds of ways of trying to treat themselves because they're getting help from conventional medicine. And so how do you use people who've got skills in the area of what some people call alternative medicine, but it's complementary medicine, I think, the sort of support for mitochondrial function and the use of what are called supplements, but which in fact are things like carnitine, CoQ, and vitamins and minerals. Is this part of the treatment regimens that you're looking at or encouraging?
Well, we're definitely going to hire a nutritionist who will ask individuals to bring in all of those supplements and begin to go through them and guide them, and certainly with their diets and so forth. We do believe that there are a lot of things that empower individuals to help themselves, and we are certainly going to support that as well. But I think those are all supplementary to a good program. But we hope to come up with targeted therapies and that bring much more relief to patients.
Well, that's very exciting and very encouraging, and we hope to build on that. Thank you very much for
Thank you.
sharing
Welcome.
with us.
Thank you for having us.